So next time a doctor, puts a stethoscope to your chest, you really should know this one thing.
Oh, absolutely.
That sound they are listening to, like that classic rhythmic lub-dub you've heard in, literally every medical drama and at every physical you've ever had.
Yeah,
It is not what you think it is.
it really isn't.
In fact, for decades, medical textbooks taught the basic physical mechanics of the heartbeat completely wrong.
Right, which is just wild to think about.
It is. Because, we all just sort of assume listening to the heart is this perfectly understood binary thing.
Like it's just a mechanical pump.
Exactly. Like the heart is a pump and we are just listening to its gears click and clack.
Yeah.
But looking through the stack of nursing and medical sources we've gathered for you today, the physical reality of what is actually happening inside your chest is, well, it's far more violent.
Very violent.
And far more complex and, frankly, a lot more fascinating than simple gears clicking. So welcome to our deep dive.
Glad to be here.
Today, we are on a mission to decode the secret language of the heart for you, specifically S1, S2, and the murmurs in between.
It's such a remarkable journey, honestly. We are going to unpack what you are, actually hearing when you listen to a heartbeat and trace the, frankly, highly awkward social origins of how we even started listening to the chest in the first place.
That story is amazing.
It really is. Plus, we'll figure out how to translate the subtle acoustic clues of extra beats, chaotic murmurs, and explore this fierce modern debate over whether this 200-year-old bedside skill is just quietly dying out in the age of screens.
Yeah, the screen age. So I want to start right at the absolute foundation.
Okay, let's do it.
Because if we're going to decode the secret language of this pump for the listener, we need to know the alphabet.
Right, the basics.
We hear two main sounds, S1 and S2. What exactly are they marking in the timeline of a single heartbeat?
So if we break it down to first principles, the heart works as a one-way pump, primarily because it has two main sets of valves. And for the blood to move forward, only one set can be open at a time. They have to alternate.
Right. Otherwise, it's just chaos.
Exactly.
No.
So S1, the first heart sound, marks the very onset of systole.
Systole being the active squeezing phase.
Right, the squeezing phase. The ventricles contract, and the pressure inside them just spikes. And this sudden, massive high pressure forces the atrioventricular valves.
Those are the ones between the upper and lower chambers, right?
Yes, it forces them to close, preventing the blood from shooting backward into the top of the heart.
Okay, so that's the lub, the very start of the squeeze.
Correct. And then we have S2, which marks the onset of diastole.
Diastole is the relaxing phase.
Exactly. This is when the ventricles finish squeezing and they start to relax so they can fill with new blood.
Got it.
So as they relax, the pressure inside them plummets way below the pressure of the great arteries they just pumped blood into.
So the blood wants to fall backward.
Right. So the semilunar valves, the aortic and pulmonic valves, they close to keep the blood from falling back down into the heart. And that's your dub.
Lub-dub. Squeeze, relax.
You got it.
I saw this brilliant detail in the notes about the timing of this cycle. At a normal resting heart rate, let's say around 70 beats per minute, diastole,
Relaxing phase.
right, the relaxing phase, actually takes up roughly 2/3 of the entire cycle.
Yes, it does.
The heart spends twice as much time resting and filling as it does actually working and pumping.
It is a fundamentally asymmetric cycle, yeah. And that long filling time is absolutely critical. It's exactly why managing a patient's heart rate is such a priority in conditions like atrial fibrillation.
Because if the heart is beating too fast.
Exactly. If a patient's heart is racing at 150 beats a minute, you're primarily robbing them of that diastolic filling time.
Yeah.
The pump is squeezing incredibly fast, but it hasn't actually had time to fill up with anything.
So it's just firing blanks at that point.
That is a perfect way to put it, yeah.
Okay, so S1 and S2 mark the closing of these two different sets of valves.
Right.
But I have to admit, I always just pictured the lub as the physical tissue of the valve smacking together.
Sure, most people do.
Like a heavy wooden door slamming shut in a draft and just banging into a door frame.
Yeah.
I assumed we were literally just hearing the doors hit the frame.
Well, you are totally not alone in that assumption. If you look at older medical textbooks from the 20th century, that slamming door model is explicitly what was taught.
Oh, really?
Yeah, the mechanical slap of the leaflets touching. But modern cardiovascular physiology tells us a completely different story.
Okay, wait, so if it's not the doors slamming together, what on earth am I actually hearing?
Think about the actual physical structure of a valve leaflet in the heart.
Okay,
These leaflets are incredibly thin. They are almost like tissue paper.
very delicate then.
Very delicate. They have very little mass. So, from a pure physics standpoint, they physically cannot produce a loud, audible thump just by touching each other. The sound actually comes from fluid dynamics, specifically the abrupt, violent deceleration of blood.
The breaking of the blood.
Yes. Back in the 1960s and 70s, researchers started putting these tiny pressure transducers and microscopic microphones directly inside the heart.
Wow.
And they discovered that the sound happens when a fast-moving, massive column of blood suddenly hits that closed, tensed valve.
So it's not the door itself making the sound, it's the sudden stopping of the rushing water against the door.
Exactly.
Like when you turn a faucet off too fast in an old house and you hear the pipes bang inside the wall.
That is a perfect analogy. The sudden deceleration of the blood against the tensed valve causes this massive acoustic shock wave. It causes the entire cardiohemic system to vibrate.
I saw that term in the text cardiohemic system. What exactly is vibrating there? Is it just the blood?
No, it's everything. The blood itself, the valve leaflets, the adjacent cardiac walls, the great vessels.
Whole plumbing setup.
Right, and even the chordae tendineae.
The chordae tendineae being those little fibrous strings like parachute cords that hold the valves in place.
Yes. So those strings pull tight, the valve balloons out slightly under the pressure, the blood crashes into it, and that entire structural apparatus vibrates at a really low frequency.
That is wild.
And that vibration radiates outward through the chest wall, and that specific acoustic event is what we call a heart sound.
The whole closing valve idea is just a convenient shorthand then. We're actually listening to blood violently breaking and vibrating the entire structural scaffolding of the heart.
Essentially, yes.
Which just makes me wonder. I mean, it's crazy to think we capture this massive violent fluid collision with just a simple rubber tube and a piece of metal.
It is pretty amazing.
How did medicine even figure out we could hear this from the outside? Like, who decided to put an ear to a chest to decode all this in the first place?
Well, to answer that, we have to travel back to 1816.
Okay, time travel.
To a hospital in Paris. There was this French physician named René Laennec, and he was examining a young woman with symptoms of heart disease.
Right.
At the time, the standard diagnostic method was called immediate auscultation.
Which means literally immediately putting your ear directly on the patient's bare chest.
Yes. And given the social mores of early 19th century Paris,
I can see where this is going.
yeah, Laennec found it highly inappropriate to place his ear directly on the chest of a young female patient.
Makes sense.
Furthermore, he noted the method was essentially useless on patients carrying extra weight because the fat just muffled the sound anyway.
There was a kind of stuck.
He was. But he recalled this simple acoustic trick from childhood.
Oh.
Yeah, if you scratch one end of a solid wood beam, you can hear it perfectly if you press your ear to the other end.
Oh, like 2 tin cans on a string, but with solid wood carrying the sound waves.
Exactly. So he took a quire of paper, just a stack of standard paper, and rolled it up tightly into a cylinder.
Just paper.
Just paper. He placed one end on the patient's chest and his ear to the other, and he was astonished. He wrote that he could hear the heartbeat more clearly and distinctly than he ever had with his naked ear.
That is incredible. A rolled-up notebook basically bypassed 19th century awkwardness and ended up revolutionizing medicine forever.
It really did. He eventually refined this paper tube into a hollow wooden cylinder. He combined the Greek words stethos, meaning chest, and skopein, meaning to examine or look into.
The stethoscope.
The stethoscope was born, and in 1819 he published a massive text where he cataloged and named many of the exact sounds we still listen for today.
Okay, so we have this evolution from a rolled-up piece of paper to the modern stethoscope. But looking at the sources on how a modern stethoscope is actually used, is far from foolproof.
Oh, definitely not foolproof.
I was reading the notes on the chest piece, the part you actually place on the patient. It has 2 sides, right? The wider flat diaphragm and a smaller cup-like bell.
Yeah.
I always just assumed you use whichever one fit best on the person's chest. But they're actually acoustic filters, aren't they?
They are entirely different tools, yes.
Oh.
The diaphragm is designed to capture high-frequency sounds. To use it correctly, you must press it firmly against the skin.
Firm pressure. Okay.
Right, because that firm pressure physically filters out the low rumbling noises, making it perfect for highlighting the crisp, high-pitched sounds of S1 and S2, or, the high-pitched hiss of an aortic regurgitation murmur.
And the bell.
The bell, however, is designed to capture low-frequency sounds, and the technique is the exact opposite.
Light pressure.
It must be applied with the lightest possible touch, just barely sealing it against the skin.
I was looking at this and thinking about how precarious that is. I mean, if you have a busy, stressed nurse or doctor and they just press the bell a little too hard against the chest.
They stretch the patient's skin taut underneath it.
Right. And that stretched skin essentially becomes a makeshift diaphragm.
You've hit on the exact reason auscultation is considered an art form. By pressing too hard, you instantly delete all the low-frequency acoustic data.
It just vanishes.
Completely.
Ugh.
A clinician could be listening to a patient with a critical low-pitched red flag, like a failing ventricle or a narrowed mitral valve, and hear absolutely nothing.
Just because they pressed too hard?
Simply because they had a heavy hand, yeah.
You could literally send a patient home with a failing heart just because of a slight change in pressure from your thumb. It requires incredible intention.
Absolutely.
So let's say the clinician has the technique down perfectly. What exactly are they listening for when they want to go beyond just a normal lub-dub? I want to bring the listener into this. If you, the listener, have ever sat on an exam table and the doctor asks you to take a deep breath and hold it while they move the stethoscope around, what are they actually doing?
They are likely listening for the splitting of S2.
Okay, S2 splitting.
It's one of the most brilliant, low-tech diagnostic tricks in all of physical exam medicine. It's essentially a 10-second test of your cardiac physiology.
Walk us through what is happening inside the chest during that deep breath.
Sure. So when you take a deep breath in, your expanding lungs create negative pressure in your chest cavity.
Like a vacuum.
Exactly like a vacuum. It literally sucks more venous blood back into the right side of your heart.
Okay, so the right side suddenly gets flooded.
Now, because the right ventricle suddenly has this extra surge of blood to pump out, it takes a tiny fraction of a second longer to empty its chamber.
So the right side of the heart falls a tiny bit behind the left side.
Yes, and because it falls behind, the pulmonic valve on the right side closes slightly after the aortic valve on the left side.
Oh, so they don't close at the exact same time anymore.
Right, so instead of a single dub for S2, you hear two distinct snaps. It sounds like lub-TA.
UPA.
And then, when you exhale, the chest pressure normalizes, the blood volume equalizes, and the valves sink back up to a single lub-DUB.
Lub-TA. Lub-DUB. That is incredible. So just by listening during a slow breath, you can literally hear the right and left sides of the heart physically separating their workloads and coming back together.
It's a real-time check of the plumbing.
And I assume this is normal.
It is audible in almost every healthy young person.
Okay.
And it matters because if that split doesn't vary with breathing, if it's what we call a fixed split, that indicates a structural problem.
A fixed split.
The classic example is an atrial septal defect, which is basically a hole in the wall between the two upper chambers of the heart.
But wait, why would a hole in the upper chambers make the split fixed? Like, why wouldn't breathing affect it anymore?
Because that hole allows blood to constantly flow back and forth between the left and right sides. The pressures are always equalizing through that defect.
Ah, I see.
So when you take a deep breath and draw more blood into the right side, it doesn't really matter. The extra volume just shunts right across the hole.
The two sides are permanently linked.
Exactly. So the right ventricle always takes the exact same amount of time to empty, regardless of whether you are inhaling or exhaling.
Man, so a fixed delay is a huge red flag for a hole in the heart.
Very much so.
The sources also mention something called a paradoxical split, where it splits on the exhale instead of the inhale. What causes the mechanics to run backward like that?
A paradoxical split suggests a severe delay on the left side of the heart.
Because normally the left side finishes first.
Right. But if a patient has severe aortic stenosis, where the left valve is incredibly stiff and takes forever to push blood through, or a left bundle branch block.
Let's define that real quick.
Here.
A left bundle branch block is essentially when the electrical wire telling the left side of the heart to squeeze gets cut or damaged, right?
Yes, the electrical signal has to take this slow detour to reach the left ventricle. In either case, the left side is so delayed that it actually finishes after the right side.
It's entirely backwards.
Entirely backwards.
So a slight changing delay is normal, but a fixed or backward delay means structural damage. But what if it's not a split sound? What if there's an entirely separate third beat? Not a split dub, but an entirely extra thump in the rhythm.
You're talking about the S3, the third heart sound.
Right.
And the golden rule for the S3 is context is absolutely everything.
Context, how so?
Well, an S3 occurs early in diastole, just a moment after S2. Remember, diastole is when the ventricle is relaxing and filling.
The resting phase.
Right. The S3 is the sound of a massive volume of blood rushing into the ventricle so fast and abruptly that it slams into the ventricular wall, causing that acoustic vibration.
It's an extra sound from rapid filling. But why does the patient's context matter so much for that?
It comes down to age and the compliance of the heart muscle itself.
Compliance meaning how stretchy it is.
Exactly. In a healthy child, a teenager, or a young athlete, their ventricles are highly compliant. They are like a fresh, stretchy balloon.
Yeah.
They can handle a massive, rapid influx of blood, and that blood hitting the walls produces a sound. So a physiologic S3 in someone under 40 is extremely common and completely benign.
But I'm guessing it's a very different story if that balloon isn't so stretchy anymore.
If you hear a new S3 in a patient over 40, especially if they have shortness of breath or a history of a heart attack, it is a massive red flag.
Oh, wow.
We call it a ventricular gallop. It creates a distinctive rhythm that clinicians describe as sounding like the word Kentucky lubdubba.
Kentucky, lubdubba.
Right. In an older adult, their heart muscle has often become stiff, scarred, and non-compliant. It's no longer a stretchy balloon, it's a rigid bucket.
And that bucket is overflowing.
Exactly.
So the heart is basically choking on the volume of blood trying to enter it. The blood crashes against the stiff wall that can't expand to accommodate it.
Yes.
I noticed the sources mentioned we use BNP blood tests for this now.
Right.
BNP is a distress hormone the heart releases when it's stretched too far, right?
Yes. A BNP test gives us a quick lab value indicating heart failure. But historically, long before those blood tests even existed, hearing that Kentucky S3 gallop was one of the absolute strongest bedside predictors that a patient was in decompensated heart failure.
That is just powerful. Just by noting the age of the patient and hearing that extra beat, you've basically diagnosed a failing, rigid ventricle without drawing a single drop of blood.
It's clinical medicine at its best.
So extra beats require deep context. Lift pivots slightly to what happens when it's not an extra beat, but when the blood flow itself becomes chaotic. Let's talk about murmurs.
Murmurs are fundamentally the sound of turbulent blood flow, as opposed to smooth, silent, laminar flow.
Turbulent.
Think of a calm, deep river suddenly hitting a section of jagged rapids. That turbulence creates noise, and they are graded on the Levine scale, which goes from grade the 4 to grade the 6.
Grade I being the quietest.
Right. Grade 100 is so quiet it is barely audible even to an expert listening in a perfectly silent room. And then grade to 4th is loud and is accompanied by a palpable thrill.
The thrill. Like, wait, you can actually feel the vibration on the patient's skin.
Yeah. You put the flat of your hand on their chest and it literally feels like a purring cat. And then you go up to grade the 6th, which is so violent you can actually hear the murmur with the stethoscope lifted entirely off the chest wall.
That sounds terrifying. Okay,
Yeah.
My instinct here, and I think most people's instinct, would be that a murmur is basically a warning siren. So louder siren equals bigger emergency.
It seems logical.
A quiet murmur is a minor problem, but a loud grade the 6 murmur means a critical near-death emergency.
That is perhaps the most dangerous clinical misconception we're covering today.
Wait, really?
Really, loudness does not equal disease severity.
Why not? I mean, if the valve is more broken, shouldn't it make more noise?
Because the intensity of a murmur reflects the amount of turbulence and the velocity of the blood flow. It doesn't necessarily reflect the anatomical severity of the valve disease itself.
Okay, I think I need an example for that.
Let me give you a concrete one. Imagine an elderly patient with critical aortic stenosis. Their aortic valve is heavily calcified. It's practically cemented shut, leaving only a tiny pinhole for blood to escape.
Sounds awful.
It is. But their ventricle has been fighting this blockage for years, and it is now failing. The muscle is incredibly weak.
Okay.
Because the heart is too weak to push blood very fast, the velocity of the blood moving through that tiny pinhole is actually quite low.
Ah, I see. Low velocity means low turbulence.
Exactly. So this patient, who is literally on the brink of catastrophic heart failure, might present with a deceptively quiet, soft murmur.
Wow.
The clinician has to actively watch for this paradox.
A dying heart might be too weak to scream for help.
That's a poetic way to put it, but yes.
That completely flips the script. And the sources also highlight the exact opposite problem, right? Where we historically overreacted to loud murmurs in perfectly healthy people.
Yes, we call it the tragedy of the cardiac cripple.
Cardiac cripple.
A large fraction of healthy children have entirely benign murmurs. The most common is called a Still's murmur.
What causes that?
It's just a harmless, musical-sounding vibration in the lower chest. The child has no structural heart disease whatsoever. Furthermore, adults in high-output states like pregnancy, or if they have a severe fever,
Right.
they can develop loud flow murmurs simply because a massive volume of blood is rushing very quickly through perfectly normal, healthy valves.
Because the pump is just running in overdrive to support the baby or fight the infection, but the valves themselves aren't actually broken.
Exactly. But historically, doctors would misclassify these harmless, loud, innocent murmurs as severe pathology.
Just because they were loud.
Yes. This led to generations of healthy children being labeled with heart disease. They were banned from playing sports, restricted from physical activity, and subjected to years of unnecessary medical anxiety.
That is heartbreaking.
They were psychologically and socially disabled by a completely harmless acoustic finding.
All because someone assumed loud equaled sick.
Hmm.
And speaking of misinterpreting sounds, I want to bring up something called the Austin Flint murmur.
Oh, the Austin Flint murmur.
When I was reading the breakdown of this and the sources, it sounded like the ultimate trap for a clinician trying to diagnose a patient.
It really is. The Austin Flint murmur is a textbook warning against treating the stethoscope like a magic 8-ball. You cannot just pattern match a sound to a disease without understanding the physics.
Okay, lay it out for us.
Imagine a patient with severe aortic regurgitation. This means their aortic valve, the main exit pipe of the heart, is leaking.
Okay, the exit pipe is leaking.
Right. So during diastole, when it should be tightly closed, blood is jetting backward from the aorta into the left ventricle.
Okay, so we have a massive leak spraying backward into the main chamber.
Now, this backward jet of blood is so forceful that it blasts right into the anterior leaflet of the mitral valve.
Wait, the mitral valve?
Yes, the trapdoor on the opposite side of the chamber. It hits that healthy mitral valve and makes it physically vibrate.
Oh, wow. So a leaky main pipe is spraying backward and rattling a completely different, structurally normal door.
Exactly. And that rattling vibration produces a low-pitched rumble at the apex of the heart that sounds almost identically like mitral stenosis.
Wait, really?
Yes, two completely different diseases. A leaky aortic valve versus a stiff, diseased mitral valve producing the exact same bedside sound.
So the trap is, you hear the rumble at the mitral door, and you just assume the mitral door is broken.
And you might plan a surgery to fix it when the real culprit is a leaky pipe across the room.
That is wild.
It separates the technicians from the true diagnosticians. A technician hears a rumble and writes down mitral stenosis.
Right.
A diagnostician synthesizes the whole picture. They check the patient's pulse pressure, they look for peripheral signs of a leaky aorta, and they realize, oh, I am hearing an Austin Flint murmur.
Okay, given everything we've just discussed, I mean, how easy it is to press the bell too hard and erase a murmur, how a quiet sound can mask a failing heart, how an Austin Flint murmur can completely trick your ear. Is this 200-year-old skill even surviving in modern medicine?
That is the subject of a massive debate right now. The decline in auscultation skills is well documented and heavily researched.
I can imagine.
There was a famous study published in JAMA in 1997 that tested internal medicine and family practice residents.
What did they find?
The researchers played recordings of basic, classic heart sounds, and the accuracy rates were shockingly low. Trainees correctly identified only around 20% of the findings.
20%.
Yes, they were missing things as fundamental as a third heart sound or a classic murmur.
That is slightly terrifying. But let me play devil's advocate here for a second. We have point-of-care ultrasound now, POCUS, right?
Yes, we do.
A doctor can literally pull a pocket-sized ultrasound wand out of their coat, put it on your chest, and look at a live high-definition video feed of the valve opening and closing.
Very true.
So if we can just see the backward jet of blood on a screen, why do we even need the stethoscope anymore? Like, why spend years training your ear when you have eyes?
The defense of the stethoscope basically comes down to utility, access, and triage. Ultrasound is incredible technology, absolutely. But a stethoscope is essentially free.
True.
It requires no charging, no batteries, no software updates, no Wi-Fi, and it emits no radiation.
It's pure analog reliability.
Exactly. And for rapid bedside triage, it is completely unmatched. A skilled nurse or clinician can screen a patient for structural disease or heart failure decompensation in under 60 seconds. In rural clinics, during disaster response, or just on a busy, understaffed hospital floor at 3 a.m., the stethoscope dictates who actually needs the ultrasound in the first place.
It's the ultimate sorting hat for medical emergencies.
That's it. When a post-operative patient suddenly can't breathe, or a patient with a fever develops a new murmur suggesting a bacterial infection is eating their valve, that immediate zero-prep acoustic assessment is irreplaceable.
Yeah, that makes total sense. So, to summarize our journey today for you, the listener, we started by dismantling the myth of the slamming doors.
Yes, we did.
And realized that when we listen to a heartbeat, we are actually hearing the complex, violent deceleration of blood vibrating the entire structural scaffolding of the heart.
Beautifully said.
We trace the stethoscope back to René Laennec's rolled-up piece of paper in 1816 Caris, which was driven by the need to preserve a patient's modesty.
Right.
We learned that holding your breath to hear an S2 split literally proves the interdependence of your left and right heart, and that an S3 Kentucky gallop can be a sign of a perfectly stretchy heart in a child, but a dire warning of a rigid, failing heart in an adult.
Context is everything.
And finally, we explored the real danger of judging a murmur by its volume, where a quiet sound can mask a dying ventricle, and a loud, innocent flow murmur can wrongly turn a healthy kid into a cardiac tribble.
It is the profound amount of clinical data extracted from nothing more than sound waves echoing through the chest wall.
It really is. And I want to leave you, the listener, with one final provocative thought to mull over today. We just talked about whether the stethoscope is a dying art in the face of modern screens and ultrasounds. But the irony in the sources is that the future of auscultation is actually circling right back to where it started. Today, AI-assisted digital stethoscopes are hitting the market.
Oh, absolutely.
They use machine learning algorithms to capture the sound waves, automatically flag abnormal murmurs, and classify extra heart sounds before the doctor even has a chance to interpret them.
It's incredible.
Which means we are using cutting-edge 21st century neural networks to do exactly what Laennec started doing with a rolled-up piece of paper 2 centuries ago. The oldest, most analog tool in the doctor's bag might just be the very thing leading the AI revolution in primary care.
It is an incredible full circle.
It's a completely new way to listen to the lub-dub. Thanks for joining us on this deep dive.